This is the approach to chest pain. This is an advanced organizer to help you keep a long list of the things that could cause chest pain, so that way you don't prematurely close. At the end, we'll round out with some things you should do every time you see a patient with chest pain. The advanced organizer is the rifle method, and it has to be a rifle because in order for it to work, you have to make sure that it goes through the person. Rifle method. Grab an AR-15, racking around, point it at somebody. The bullet is traveling at a high velocity. If it hits someone's chest, it's definitely going to the other side. And what you should do then is think of all of the layers that bullet is traveling through, and then think of the things that could be causing pain at that layer. So we start on the outside, which is the skin. Then the subq. The muscles and bones are right underneath that. The pleura. Now the lungs don't feel pain. The pleura does. The pericardium. Then the heart. Behind the heart you have the esophagus and the trachea. And lastly, the aorta. These are things that cause pain. At the skin, it's not going to be a mystery, right? You're going to just look at it and see. But things you should think of with the skin are things like lacerations, burns, bites or stings, and don't forget about herpes. Shingles. They can be painful before you see the lesions. In the subq, same thing. You're just going to be able to look at it and see, hey, oh, hey, there's a cellulitis or an abscess. In the musculoskeletal, you're looking at both the muscles and the bone's cartilage. Right, so because there's muscles, you can have sprains or strains. Of course, fractures of the bones themselves. And then the most common cause of chest pain presenting in the ER. Costochondritis. The thing about MSK pain is that it is very easily reproducible, usually with palpation. That is to say, MSK pain is usually tender. If it's broken or inflamed and you push gently on it, you're going to feel pain. And likewise, if you just get the patient to use their muscles, if the pain is coming from their muscles, it'll hurt more when they use them. The pain of the pleura, that is the lung. Lung doesn't feel pain, but the pleura does, which means that in order to feel pain from a pleural disease, you have to be in contact with the pleura. Therefore, they are the P's. Pneumothorax, pneumonia, pulmonary embolism, pulmonary cancer, and pleurisy. And the nice thing about the pleuritic diseases is that the pain will be pleuritic. That is, a deep inspiration exacerbates the pain. And they don't have to have pain right now in front of you. You can actually ask them, did you try to take a big deep breath to calm down? Did that make it better or worse? Pericardium is another P. Pericarditis. Not so much a pleuritic pain, but one that is positional. If you hear a positional chest pain or in the epigastric region, you can consider pericarditis or pancreatitis. Now the heart, notice how long it took us to get there. Most people see, chest pain, I gotta roll out an MI, right? Okay, but that's not the long list, right? Myocardial infarction is of course on this list, and this is all forms of angina, whether it's STEMI, NSTEMI, stable, unstable, whatever. Heart pain. The heart can also hurt if it's inflamed, myositis. The goal here is to show you, hey, there's a lot of things you should consider. Yes, myocardial infarction is going to kill somebody, but most people who present to the ER with chest pain don't have an MI. It's your job to find out what it is. Esophagus. Another very common cause of chest pain is reflux, GERD, which leads us to other forms of esophagitis. Perforations will hurt too. Boerhaave syndrome. The trachea, this is very rare, but it's to make the method work is one of the structures, so you need to consider it. Tracheitis and perforation. In the aorta, a dissection, a tearing of the wall hurts. And in the same vein, aneurysm. All right. So this is the approach, the rifle method, thinking about the different layers that the bullet would pass through and thinking about the diseases that could be caused at that level. Now, what do you actually do? Right? If you go to the ER and say chest pain, you're going to get a chest x-ray, a 12-lead ECG, and a troponin. And that rules out the MI and gives you a good look inside the chest. Not a great one, but a good one. Then you come by and simply ask a couple things. Right? First, you do want to make sure it's not an MI. It's really easy to do that by asking a couple of questions. Those questions are on the Diamond-Forrester classification. That is the pain substernal? Which you're of course going to ask, where is the pain? But you have to ask yourself, is it substernal? Is it worsened with exertion? And is it improved with nitroglycerin? Then you're going to do the physical exam and find out if it's tender, pleuritic, or positional. You add to that, because this is for free, blood pressure in both arms. While you're doing the interview, you just put the cuff on once and press the button. When it's done, take it off, move it over to the other arm, push the button again, continue the interview. Asking these questions, doing that simple physical, can get you very close to the answer. And yes, you do want to get a chest x-ray, 12 EKG, and a troponin, especially if someone has something that sounds like a crushing substernal chest pain that could be myocardial infarction. The last thing you can do, and it's unique only to the esophagus, is a GI cocktail. And GI cocktails include viscous lidocaine. That is, if the pain gets better with the administration of lidocaine, chances are whatever the lidocaine touched was causing the pain. And if you swallow a GI cocktail, the only thing it should come into contact with is the esophagus. So you can rule in and rule out that the pain is from the GI lumen by giving a GI cocktail. That is the approach to chest pain.